Welcome to PGOG postgraduate class in obstetrics and gynecology, and today's topic is vaginal hysterectomy. In the minimally invasive surgeries, if we compare the most minimally invasive for the gynec pathologies is considered as vaginal hysterectomy, followed by a laparoscopic hysterectomy or robotic hysterectomy, and the least invasive we can say is, or the maximally invasive we can say is open abdominal hysterectomy. Now, vaginal hysterectomy has comparable outcomes with laparoscopic hysterectomy, with less operative time required, less expenses, and early post-operative recovery. Indications of vaginal hysterectomy are usually for benign uterine pathologies, where the pathology is confined to the uterus, such as most common is pelvic organ prolapse, leiomyoma uterus, abnormal uterine bleeding whenever hysterectomy is indicated, endometrial hyperplasia especially, or typical endometrial hyperplasia, cervical intraepithelial neoplasia, and severe dysmenorrhea. Requiring hysterectomy. Now, there are certain contraindications which are not absolute. We can say these are the relative contraindications, such as a very large uterus with a size more than 12 to 16 weeks and where size reduction is not possible. Presence of extrauterine pathology with inaccessible pouch of Douglas or cul-de-sac, or with severe pelvic adhesions, or with severe endometriosis. Preoperative care, consent is most important part of consent is consent to proceed with abdominal or laparoscopic. Surgery has to be present. Enema night before surgery can be given, but some surgeons do not prefer it. Shaving is not advisable for all the surgeries. Now, what if necessary, what you do is the hair clipping. Now, vaginal hysterectomy is a type of clean contaminated procedure because vagina itself has organisms and we are entering through the tissue which already has organisms, and that is why it is a type of not a clean surgery but a clean contaminated procedure. And for this reason, preoperatively treatment of bacterial vaginosis with metronidazole is important to reduce the incidence of postoperative infection or cup cellulitis. Perioperative antibiotic administration is advisable, where one dose of injection cefazolin intravenously 2 grams is given within usually 60 minutes of incision. Now, if the patient is sensitive to penicillins and cephalosporins, then a combination of metronidazole clindamycin or clindamycin with gentamicin can be given. If in a case of prolonged surgery or excessive bleeding, second dose of the antibiotic to be given. Now, for vaginal scrubbing, usually povidone iodine is preferred over 4% chlorhexidine, as there is an issue about the FDA approval for its use for vaginal cleaning for chlorhexidine. In the steps, either regional anesthesia can be given or general as per the patient's or anesthetist decision. Lithotomy position, cleaning and draping is done. Now, either one can keep a indwelling Foley's catheter or one can proceed with intermittent emptying. Now, the advantage of intermittent emptying is a slightly full bladder can help us to see the limit of bladder whenever we are opening the anterior colpotomy, whenever we are doing the anterior colpotomy. Examination under anesthesia is the most important step in the initial steps of vaginal hysterectomy, and mainly here we have to again reassess for the size, shape, and mobility of uterus. Under anesthesia, we can in a better manner say if the uterus is fixed, it might be because of the presence of adhesions, and then we might have to take a decision to proceed with the abdominal procedure. Similarly, we should see for adequacy of the vagina, especially whenever a patient is a nulliparous woman. and we have to confirm the extent of cervical descent, which can best be judged under anesthesia. Now about the first incision when we start the procedure, either it can be started as posterior colpotomy to start with a posterior incision, which is from 8 to 4 o'clock on the posterior vaginal wall, or one can give a circumferential incision all around at the cervicovaginal junction, anteriorly, laterally, as well as posteriorly. We have to, what is most important is we have to cut full thickness of the vaginal epithelium or vaginal mucosa. If we are giving incision which is too shallow, we will be entering into a wrong plane. And if we give too deep an incision, then we will be entering into the cervical tissue, and that will lead to excessive bleeding. So we have to identify first the best site of incision anteriorly as well as posteriorly. We can do the infiltrate the vagina. Now it is surgeon's choice. Some surgeons are doing vaginal hysterectomy throughout their career by infiltrating the dilute epinephrine or vasopressin as 1:2 lakh dilution, vasopressin 20 units in 100 ml, and 10 to 20 ml is infiltrated, or if you want hydrodissection, then up to 100 ml also can be infiltrated all around where you want to give the incision. But only word of caution is whenever we infiltrate, anatomical landmarks are not visible. And that is the reason usually it is said that the site of incision needs to be identified before we do this hydro dissection or before we infiltrate with the vasopressors. Then we can give a circumferential incision at cervicovaginal junction, or we can give only a posterior incision, but we need to cut through the full thickness of the vaginal mucosa or epithelium. If we start, usually it is advisable to do posterior colpotomy first, followed by the anterior colpotomy. Now, when we do the posterior colpotomy, sharp and blunt dissection is to be done to reach to the posterior fold of peritoneum or pouch of Douglas. So there is a combination of sharp and blunt dissection usually helps us to reach to a point where we can see the slippery posterior peritoneal edge, and then we can open it. So this is the posterior vaginal edge. Usually it has some bleeders as we do the blunt and sharp dissection here. Some bleeders might open and bleeding might start here. And that is why we should be taking, once we open the pouch of Douglas, then including the parietal edge and posterior vaginal edge, we can take at least 3 or 4 sutures like that. These will be the hemostatic sutures, and we can keep the ends long. Central to sutures, we can keep the ends long for the identification of posterior peritoneum whenever we want to do either a macroscaldoplasty or we might want to suture the vagina after hysterectomy. This is important step I want to stress once again. Otherwise, what happens is if we fail to take these hemostatic sutures, then multiple times we are introducing the speculum inside and removing it, and that speculum itself leads to further trauma to the posterior vaginal edge with further opening of bleeders, and unnecessarily patient is bleeding from this edge, and that is why these hemostatic sutures prevent that blood loss. We have to hold pouch of Douglas peritoneum, confirm there is no bowel loop, and then incise it and extend laterally so that we can put a speculum to protect the rectum posteriorly. As I said, speculum can increase the bleeding from posterior vaginal edge with repeated removal and insertion. So hemostatic sutures including posterior peritoneum and vaginal edge is an important step. We can hold the peritoneal suture long for further macular scaldoplasty or for the even the closure of the vagina. So at the end, this will be the picture. There is no bleeding from the posterior edge of the vagina, open vagina, and this is the space where we can put the speculum inside, and these are the long sutures which are kept for the future identification of posterior peritoneum and vagina. This is the same speculum which is in place so that we are protecting the rectum when we proceed with the hysterectomy. Now the next step is to go for anterior colpotomy. Now what is most important is correct placement of anterior incision. Either it can be a part of circumferential incision or we can take only anterior incision from 10 to 12 o'clock depending on surgeon's choice. Saline or vasopressor infiltration might distort anatomy is the most important message here I want to give, that there is advantage with this infiltration, that it helps in hemostasis and it leads to hydrodissection, and that is why easier separation of the surgical planes sometimes, but it might distort the anatomy. We should remember that also. We need to avoid blunt, forceful dissection with excessive force when we start the dissection of anterior vaginal wall from underlying cervical stroma. It is better to do a sharp dissection. Once we see the slippery and glistening vesico-uterine fold of peritoneum, that means we have reached to the correct plane. We are in the correct plane and we need to open this fold of peritoneum, and speculum needs to be inserted with lateral extension of the opening of the peritoneum so that we can protect the bladder anteriorly. Now here, taking the first incision for anterior colpotomy is almost like battle half won. If your placement of the incision is correct, your hysterectomy is easier, vaginal hysterectomy. So how to know where to give the incision for anterior colpotomy is, if you carefully see the anterior vaginal wall by putting a Ellis forceps at the anterior lip of the cervix and bringing down the vagina, what you will understand or appreciate is there is a small bulge of bladder bulge is seen, and if patient has cystocele, it might be a bigger bulge. Below that, always a small crease is appreciated. This crease, transverse crease, coincides with the cervico-vaginal junction, and our incision should be just below that transverse crease. So that is the main landmark which helps us to decide where to give the transverse incision. If we do not identify this transverse crease and we give an incision which is too near the cervical os, that will lead to entering into the wrong plane. We might go in the deeper plane in the cervical tissue with the occurrence of excessive bleeding, and our planes are wrong. The surgery also is prolonged and anterior colpotomy may seem to be becoming more and more difficult. On the other hand, if we give too high an incision, there is a risk of going for a bladder injury, and that is the reason this first incision, selection of the site of the first incision of anterior colpotomy is the most important step in vaginal hysterectomy. Once we give the incision, then with Elias tissue forceps at the superior edge of the incision, we need to elevate the superior edge, and then we start doing a sharp dissection with initially pointing the scissor perpendicular to the cervix. If we go parallel to the cervix, we are likely to again injure bladder. Remember that. So our scissor direction should not be parallel to cervix, but it should be initially perpendicular to the cervix when we do the sharp dissection. Then with a combination of sharp and blunt dissection, which we reach anteriorly up to the slippery peritoneum, and we open it. Once we open the peritoneum, we can, with the finger, we can palpate anterior surface of the cervix as well as uterus. That indicates that our identification of the peritoneum is correct. Our surgical plane is Correct. Now next, after the posterior and anterior colpotomy, we start with the ligation of the pedicles or separation of the various ligaments with which the uterus is attached to the surrounding tissues. And for that, we have to elevate the cervix and put the this Ehlers tissue forceps on posterior lip of the cervix, and then we can appreciate the uterosacral ligaments which are going from center to slightly laterally. So with palpation, with finger palpation, we need to identify these uterosacral ligaments, and then we put the first clamp of vaginal hysterectomy to separate the uterosacral ligaments posteriorly. Now this we should be doing a double clamping whenever we are applying the clamps over the uterosacral ligament. This clamping should be as near to the cervix as possible, as ureter is passing. Remember, ureter is passing just beneath the uterosacral ligament, and if we clamp it laterally away from the cervix, there is a risk of ureteral injury. Now the important is the how we suture the pedicles. We cut medially and ligate laterally. So how we suture the pedicles is one of the technique is called as transfixation, which is also called as the Heaney suture. As we use the Heaney's clamps, the suture is also called as Heaney suture. For that, what is done is first you pierce the pedicle near the tip of the clamp, bring it out, then encircle the pedicle, and then go back and come out through the center of the pedicle, and then ligate. This is called as Heaney's transfixation suture. For vascular pedicles, or initially when you are a beginner or a learner, then it is better to do double suturing of all the pedicles. So the Heaney transfixation suture, where you first come through the tip of the clamp, encircle and go back and come back through the center of the pedicle. Tip, encircle, come back at the center. That is Heaney's transfixation suture. Second way of pedicle ligation is central ligation, where you pierce at the center and then you ligate on both the sides up and down. Usually this central ligation is not advisable whenever you are doing a uterine artery pedicle, because needle can pierce through a vessel and unnecessarily there will be more of bleeding. For such vascular pedicles, it is better to first take a free tie and then second suture medial to the free tie. You can take it either as a Heaney transfixation or central ligation. Now tips for better hemostasis and healing. Now what is important in vaginal hysterectomy is after we clamp and cut, what is most important is how we ligate. Because if our technique of ligation is inaccurate, there can be a retraction of a vessel from pedicle, and then post patient can go for injection because of that, and that is why mistakes are important. Always use two clamps as far as possible whenever you want to separate a ligament. So you can use Heaney clamps. Always double ligation of pedicles is advisable, such as you can do the combination of transfixation and central fixation, or you can first take a free tie followed by a transfixation or central fixation, like that. But double ligation of pedicles adds to the safety and better hemostasis. Always first knot should be a double knot. That is for lifelong for all the surgeons. You should remember whenever you are tying a knot around the pedicle or anywhere when you are operating, first knot should always be a double knot. Then one should not be moving the clamps too much. The assistants who are holding the clamps, you should instruct the assistants not to move the clamps too much, because that will lead to the this retraction of the vessels out of the pedicle. Then assistant should not be pulling on the clamp, especially in elderly postmenopausal women, as tissues are friable. That can add to the tissue trauma and bleeding later on. Pedicles which we keep, this should not be too long and this should not be bulky. Otherwise, it will lead to formation of a large necrotic tissue, which is a very good bed for the organisms to grow and which is a risk factor for post-operative infection. Now about the this here what I have shown is a cervical elongation. Now cervical elongation is seen in some patients, especially with a pelvic organ prolapse. And what is the reason of cervical elongation is there is a vaginal elongation part of the cervix which is getting elongated, and it is because of the excessive stretch or tension of the level 1 supports. Level 1s are the uterosacral and cardinal ligament, which are partially trying to maintain the normal anatomical position, but if pelvic floor is lax, then there is a tendency of the cervix to descend, and with that there is a stretching of supravaginal part of the cervix that leads to cervical elongation. In this case, we need to apply more than one clamp whenever we want to separate cardinal or McEnroe ligaments like this. This is the first clamp. Then we have to again apply the second clamp for remaining part of the McEnroe's ligament, because there is excessive stretching of the cervix along with excessive stretching of the cardinal or McEnroe ligament. Now about the size of pedicles. Now here if I apply single clamp to whole of this McEnroe ligament, what it will lead to a formation of a bulky or thick pedicle. Or if I apply clamp too much lateral, it is dangerous for ureteric injury also, as well as it will lead to the formation of a long pedicle. Length of pedicle should not be of the part which is distal to the clamp or which remains in the body. It should not be more than 0.5 centimeters. And if it is too long, then again the necrosis and infection risk is more. Now, whenever we have to do successive clamping, what is most important, especially with the cervical elongation and for cardinal ligament, is second clamp should be medial to the first and no tissue should be left in between whenever we are applying the second clamp. Here, as you can see, this was the limit of first clamp, and then the clamp is applied directly here, but we have cut till this level. So tissue has been cut, but we have not clamped or ligated. This is a place from where there can be a vessel retraction and it can lead to the excessive hemorrhage intraoperatively or post-operatively, which can even be life-threatening. So in vaginal hysterectomy, remember successive clamps are medial to the initial first clamp, and always it has to be just in proximity to where the first clamp ended. Ligament separation, the principle is clamp cut medially, ligate laterally whenever we are doing vaginal hysterectomy. First clamp is uterosacral ligament, pedicle, first pedicle. Always you have to clamp it as near the cervix as possible to avoid ureteric injury. We can either keep this suture long, or at the same time we can transfix the uterosacral ligament, anchor it to posterolateral vagina as a to the vaginal angle, so that the vaginal angle will get a support of uterosacral ligaments. If we want to, we plan to do macral spaldoplasty, especially to prevent enterosil or treat enterosil, then we need to keep these uterosacral ligament sutures long, so that to do the procedure after completion of hysterectomy. Now, cardinal ligaments, we might have to take more than one if there is a cervical elongation. Uterine arteries, now uterine artery pedicle, we should never be holding any vascular pedicle long. Otherwise, what it will lead to? It will lead to slipping of the pedicle and retraction of vessel. This is one surgical principle. Secondly, we need to apply a clamp perpendicular to the cervix. So nicely open the clamp and apply it perpendicular to the cervix and slide it off the cervix so that we include all the branches of uterine arteries. And then we need to cut medially, ligate laterally. Ligation first, we can have a free tie followed by either a transfixation or central fixation suture. Double ligation is advisable. Next clamp after the uterine arteries is broad ligament clamp, which is usually necessary whenever the parous uterus is there, slightly enlarged uterus is there. And this broad ligament has utero-ovarian vessel anastomosis, so we need to be again careful to ligate it properly. And then we come to the last clamp, that is at uterine cornu. For this, fundus can be delivered through posterior colpotomy. If you find approach to the corneal clamp is not easier initially. Always ensure proper ligation of pedicles and confirm the hemostasis after ligation of each pedicle. So this is diagrammatically. First is clamp to the uterosacral, and the clamps are to be put again perpendicular to the cervix and as near to the cervix as possible to avoid ureteric injury. Then the cardinal ligaments clamps are parallel to the cervix, and we might need to take multiple apply clamps at 2 or 3 times depending on the cervical elongation. Successive clamps are to be medial to the first clamp. For uterine vessel, again the clamping is perpendicular to the cervix, and we have to just open the clamp and then slide it off the cervix so that the clamp is closed just lateral to the cervix, and all the vessels, branches of the uterine arteries are included in the clamp. Next is broad ligament, where there can be vessels with anastomosis of uterine artery with the ovarian artery, and last is the corneal clamp, where again there is a rich anastomosis of uterine and ovarian vessels, and that is why that also needs to be clamped properly. Now, once we remove the uterus, confirm hemostasis by inspecting all the pedicles. You can go in a clockwise manner and inspect all the pedicles once again for confirmation of hemostasis. Macal scaldoplasty can be done to prevent or treat enterosil, or we can, and for apical support also to give a apical support, or we can do just anchoring of uterosacrals to angle of the vagina. Vagina is closed either with interrupted sutures, or we can take running sutures and locking. So running suture can be taken if bleeding is present from the vaginal edge. But what is most important is we have to include full thickness of the vaginal edge. Cystoscopy can be done especially whenever there is a difficult vaginal hysterectomy, and if there is a difficult anterior colpotomy, then in that case cystoscopy can be done to confirm the patency of bladder, as in that bladder is a patency of ureters, and there are no sutures which are going through the bladder. Now, some challenging situations during vaginal hysterectomy which we can encounter are: first is difficult anterior colpotomy. When we do anterior colpotomy, it is almost like half of the tension goes off. What remains is next is applying the clamps correctly and correct suturing technique of the pedicles. But what is most tricky for vaginal hysterectomy is anterior colpotomy, because all the time we are worried about a bladder injury whenever we are proceeding with a anterior colpotomy. So some cases anterior colpotomy might be difficult. Long cervix leads to the presence of anterior and posterior colpotomy, both sides, which become at a higher level, and that adds to the problem. Even posterior colpotomy might become difficult with a long cervix if uterus is large. Now, though we say relative contraindication is size of uterus more than 12 weeks, or for some vaginal surgeons It can be more than 16 weeks. It differs from person to person, surgeon to surgeon. But a large uterus also can pose a challenge. And if cervical descent is minimal, especially with a previous cesarean section or nulliparous patient, that might add to the difficulties while doing the vaginal hysterectomy. So how to overcome these difficult situations is, if anterior colpotomy is difficult, such as because of previous cesarean section, long cervix, or vasoconstrictor infiltration, or because you have done initially blunt dissection and you have entered into the wrong plane, and this can lead even to the bladder injury also if you put too much of force, and with excessive force you start doing blunt dissection anteriorly, bladder injury also can take place. So better to do a sharp dissection to overcome the difficulty. And the dissection, when we want to dissect the anterior vagina from underlying cervical stroma, dissection should be nearer the cervix. If we do dissection away from cervix, we are likely to enter again into the bladder, so that remain close to the cervix, but do not enter in cervical tissue. Once we enter into cervical, how we know we have entered in cervical tissue is excessive bleeding slips. That means we have entered into cervical stroma, and we will never be able to get into the correct surgical plane, and we will never be able to reach to the anterior peritoneum, and that will lead to the difficult anterior colpotomy. So too deep we should not be in cervix, but we should remain close to the cervix. We can use bladder sound to identify the bladder margin. Whenever there is a doubt where is the bladder limit, we can use the bladder sound, and we can then at the start of the procedure, if intermittent catheterization is to be done, we catheterize whenever we start doing surgery. We can repeat the catheterization, empty the bladder, then put the bladder sound and see where the margin of the bladder reflection is. Another way of overcoming difficulty is, we can put a finger or a curved instrument through posterior colpotomy, bring it anteriorly to identify the anterior peritoneum, and glistening peritoneum and your finger underneath gives us the confidence to open the anterior peritoneum. It tells us that we are not opening the bladder, in other words. If cervical elongation is there, then first try posterior colpotomy. That is also not possible, then we need to do uterosacral ligaments first. That helps in entering the posterior pouch of Douglas, posteriorly pouch of Douglas. Anteriorly, we should push the bladder up, and then first we have to go for cardinal ligament separation, and even we can go for a uterine artery pedicle also. That usually helps us to identify the anterior fold of peritoneum, uterovesical fold of peritoneum, and we can do anterior colpotomy here. But the most important precaution is, bladder should be nicely dissected up, pushed up, before we apply clamp for cardinal ligament, or we apply a clamp for uterine artery ligation. Now, if it is an enlarged cervix, enlarged uterus, then various morcellation techniques help us to overcome this problem. All these morcellation techniques are to be done after all branches of uterine vessels are ligated, and anterior and posterior colpotomy has already been done, and bladder has been pushed up. Then only we can try these morcellation techniques. Three things we need to remember: that uterine vessels, all branches are ligated. That means we might have to take first uterine clamp, and we should be taking a second this broad ligament clamping also, so that we include all the vessels, even where your anastomosis of the uterine with the ovarian vessels also is taken care of. Then we should ensure that we have entered anteriorly and posteriorly, and both colpotomies have been done, so that the rectum and the bladder are protected by putting the speculums through these colpotomies. And bladder should be nicely pushed up. Then only we can start the morcellation techniques. One technique is bivalve the uterus, or cut the uterus in two halves. make the two parts of the uterus until you can see the fundus. So hold the cervix at 309 and 3 and 9 o'clock and start cutting anteriorly as well as to the posterior wall of the cervix and uterus also in the midline anteriorly and posteriorly. That reduces the bulk of the uterus, and usually you can visualize the fundus, you can visualize the cornu as you approach superiorly. So this is bivalve technique, which is very, very useful whenever we are especially doing vaginal hysterectomy without descent. When a patient has no pelvic organ prolapse and we are doing a hysterectomy, sometimes that technique is called as that hysterectomy is called as a non-descent vaginal hysterectomy, but that terminology is not used in some textbooks. It is included under vaginal hysterectomy only. But in these cases where the cervical descent is minimal or absent, then in that case this bivalve technique helps us to reach to the approach the fundus and the cornu and to apply the clamps under direct vision. If a patient has fibroid and pre-operatively only we need to do the mapping of the fibroids, where the fibroids are, and then accordingly we should be doing myomectomy as we go superiorly. So after the ligation of uterine vessels, we apply the clamp for broad ligament, and if there are any myomas, first do the myomectomy. That will also lead to the volume reduction of the uterus. Or one can go for intramyometrial coring. It is also a useful technique where what you remove is you remove the myometrium but keep the layer of the myometrium near the serosal surface intact. Only do the coring, central coring. Once we remove the central tissue, that also reduces the size of the uterus and the fundus and the cornu becomes approachable. If descent is minimal, such as in a nulliparous woman or with a previous caesarean section, then in that case, first posterior colpotomy should be done. Uterosacral ligaments and cardinal ligament separation to be done. That leads to the descent of the cervix. Once these ligaments we clamp and we cut these ligaments and ligate these ligaments, it leads to the cervical descent, and then we can proceed with the anterior colpotomy. Now for budding gynecologists, some tips or advices: do not compromise safety for speed. Now this is most important. Whatever surgery you do, never compromise patient safety for the speed. Read from various books and review articles multiple times. At least for initial 15 to 20 vaginal hysterectomies, each time you are supposed to operate on a patient next day. One day prior, you read from various books. Each time you read from a different book, you will get a new tip. So many books are available on operative gynecology, and so many authors have given wonderful descriptions of the techniques. So go through various books, go through the review articles also which are available. Watch the videos repeatedly, at least one day prior. Watch the video of the technique repeatedly. That also helps us whenever we encounter a difficulty while operating. Be patient, be humble. The day you become arrogant as a surgeon, remember that you are inviting trouble. That day only some intraoperative complication you will face. Remember that we are answerable only and only to our patients. You are not answerable to your anesthesia friends to do a fast surgery. You are not answerable to even your colleagues also. You do not want to have arrogance of being a fast surgeon. Remember that patient doesn't say that please operate and finish up my surgery in so and so minutes or hours. What is patient's only request is please give me a good post-operative result. And that is the reason, remember that whenever we touch a patient, we operate on a patient, we are answerable to only and only to our patients. That we need to keep in our mind whenever we are waiting. Thank you so much.